I was tasked with with introducing our speakers. So for a first guest, I want to just say welcome to everybody that has come to this wonderful hot topics, and I'm delighted to have um, Jane Dimnwaobi. I hope I pronounced that correctly, and John Vick. And I'm going to start with Jane. And she is an Equal Justice Works Fellow at the Tennessee Justice Center. And her work there combines direct representation of individuals receiving health care and nutrition benefits with tracking the impact of social drivers on health equity in communities across Tennessee. And Jane earned her law degree in 2023 from Vanderbilt, and we're just so happy that she is here doing this fellowship. It just sounds amazing, and I've been lucky to hear you moderate some discussions about Medicaid and SNAP, and thank you for that. And then next we have Dr. John Vick. He received his PhD in community research and action from Vanderbilt longer time ago than Jane received her JD. I'm just going to say that, John Vick. He's the director of the Office of Primary Prevention at the Tennessee Department of Health, where he leads an interdisciplinary team that works in communities across the state to address social drivers of health. I was lucky enough to be able to work with John a few years back in the Office of Primary Prevention before I retired. These drivers of health include things like housing and transportation, food systems, and green space. And the vision of the Office of Primary Prevention is that everyone in Tennessee can make healthy choices wherever they live, learn, work, play, and pray. So without further ado, and oh, by the way, I'm Patty Scott. I serve on the health committee of the League of Women Voters, and that committee is the one that got this together. So Jane, I'd love to start with you, and you talk about what you're doing, and then we'll have plenty of time for discussion and questions. All right, thanks, Jane.
Okay. Yeah, thank you so much, Patty, for the introduction. I'm so excited to be here with John. I think our presentations on community health and social drivers of health generally will connect really well together. So I'm going to talk to you all about, like Patty alluded to, the data and information around health, and then how that connects to health and nutrition, and how that connects to TJC's work. So I have a presentation that I will share, and then most of the time we'll be walking through some of the resources that I've created. I'm so sorry, I forgot to ask. I'm going to send a request to share my screen, and hopefully somebody gets that.
And I'm not quite sure
Oh,
who does that.
it's done.
Ethel, is that you? Can you?
Somebody just approved it, so I'm good to go.
Okay, good.
Great.
Must be some magic person behind that voters
Yeah,
picture there.
I'm grateful to that person. So
Or it's a robot. It may be a robot, Jane.
okay, so I am so excited to talk to you all about my work at TJC. Like I said, Tennessee Justice Center, if you're not familiar, is a nonprofit law firm and advocacy organization based right here in Nashville. And our work is all around health access and nutrition access. And we've been around since 1996. Sorry. A little bit about myself and my project. Patty gave you the overview, but I'll talk a little bit more about the Equal Justice Works fellowship program and the work I've done so far. So Equal Justice Works is a legal fellowship program that pairs recent graduate attorneys with nonprofit organizations to do high impact and timely public interest legal work. So that for me is the data behind the casework. So folks at other attorneys at TJC represent individuals who are on a Medicaid, which you might know as TennCare, or people who are on the SNAP program, which you might have heard to refer to as food stamps. So we're helping people get food, we're helping them get health care, but a lot of the times we recognize through our work that the problems that they experience start before they walk through our doors, and actually start before we're even talking about these programs that we're taking to appeals and why we're having litigation. So my fellowship project is really to contextualize TJC's work and bring as many people as possible up to speed with the need for, again, for our work, and also just the extent to which there are health disparities across the state. And so I'll be talking to you all about the output of that, which is, again, a data-focused resource that I hope you all will use. But really, my fellowship is exactly this, talking to people who kind of know about TJC, about the context and the broader situation in Tennessee that even leads us to need an organization like TJC. So, like I mentioned, TJC is a nonprofit law firm and advocacy organization. We do direct representation, which means, like what I said earlier, we work with individuals that come through our doors and say, hey, I'm supposed to be insured by TennCare. Something happened, I can't get my medication. And we'll actually work with that individual directly to get them to a resolution, ideally to the coverage that they need. We also do policy and advocacy. So we are in communities talking to individuals, getting them up to speed on everything they need to know if they want to advocate for better access to healthcare, or if they themselves need access to healthcare. And we work with legislators. We push policies, we track federal policies and state policies that are impacting the people who need these programs the most. And then finally, we do litigation. Sometimes when we see issues are happening on the systemic level, we'll actually bring these large scale class actions to correct. Our hope is to correct the problems at the agency level. So TGC is able to kind of touch on a couple of different ways of achieving results so that people do have access to healthcare and nutrition. And what I hope to show you is that data is behind a lot of that. So what is health equity? What are we even talking about here? Health equity is achieved when every person, regardless of race, income, education, gender, or other demographics, has access to what they need to be as healthy as possible. So when we're working towards health equity, we're trying to eliminate the illness disparities, income disparities, racial disparities, any disparities that makes it hard for everyone in Tennessee to have a high quality of life. So health equity is the mission towards eliminating health disparities, to put it simply. And a lot of my work is making sure everyone's aware that that's a capital we, everybody, is moving towards health equity for all Tennesseans. And the way that I've approached the conversation around health equity is to show that if you want to understand health disparities, you have to understand the social drivers of health. You have to understand that there are all these aspects of a person's life that affect their health outcomes that has nothing to do with whether they go to the doctor or not. I mean, and the point being, a picture of health actually starts before we're even talking about a medical issue or an illness. And that's really the conversation around SDOH, or the social drivers of health. Um, we focus mostly on economic stability, education, access to healthcare, what neighborhood someone lives in, and their community. And all of these, there are also other ways you can interpret social drivers of health, but this is just a start. And this is kind of like what I'll be focusing today's conversation on. So we want everyone to have a high quality of life. That's equity. We recognize that there are disparities that are preventing us from all having high quality of life. That's the health disparities. And we want to use addressing or talking about the social drivers of health to kind of bridge that gap. So the question is, how can we eliminate health disparities if we don't know what they are and where they exist? And that is really where my project comes in. It's allowing us all to be as informed as possible through the most accessible resources, allow us to be the most informed as possible about where these health disparities are and what they are, so that we can hopefully move towards fixing them. So this map is a bit of a preview. This is what I've created is an educational map feature that allows people here in Tennessee to explore all the different counties, all 95 counties, and the data for each, and kind of, again, start that education. So the why for this, the why behind a data focus to health disparities, is because data is really important. Data is the reason that we can measure issues. And if we track issues, we're in a much better position of fixing them than if we didn't track them, right? So there's kind of this idea that if we are able to measure the problems that people are facing, we can then create actionable solutions to fix those problems. Data is is the way that we get new information about problems in our state. It's the way that we deepen our understanding about problems in our state. So if we already know something is happening because we see it in our clients, we might want to use data to give us more of a larger scale picture. So maybe we saw this affecting one person, but we want to know, does it affect a larger percentage of the population? Data is being collected every day, all the time. And so we have an opportunity to give it a purpose and to give it an application and really use it to our ends, which is, again, eliminating health disparities. And when we look through data, we might notice that there are actually gaps in available data. So there are things that aren't being collected and there are things that aren't being reported. So looking through data and analyzing data is a great way to identify those data gaps, and we can learn a lot from those data gaps. And again, with the why behind the dashboard is for us to move towards health equity for all Tennesseans to the extent that we're prepared to kind of confront what we learned from the data. So without further ado, I'm going to share with you all the actual dashboard. This is what I've created. It's called the County Health Equity Data Dashboard, and it lives on TJC's website. We've created this as, again, a way for people to really understand whether they're interested in economic stability, nutrition, maternal health, behavioral health, that there's information out there about who is doing well in Tennessee and who's not, and hopefully we can focus our attention on where we need improvements. So I'll navigate to the dashboard once I move to the next slide, and we'll spend the next 5 or so minutes walking through some of that information. I think you all will find that very interesting. So what we'll focus on is some of this. So economic stability, we'll look at the median income for counties across Tennessee, and then just kind of tie that to overall health outcomes. We'll look at maternal health, which is to say we'll review the counties that have difficulty accessing maternity care and just have a general high maternal vulnerability. We'll look at the counties that have low access to providers. So that just means there aren't very many hospitals, there aren't very many doctors, and there's maybe a lower life expectancy. And we'll look at food access. So food insecurity across Tennessee and kind of how we can understand why people struggle to get access to healthy food. So I'm actually going to stop sharing and switch over to a different screen if Zoom will allow me. Great. So the resource I'm going to share with you all is actually housed on the TJC website. TJC has a website chock full of information that you all might find helpful. So this is a resource. This is a tool that hopefully people can use to educate themselves and get inspired and get activated. So if you go to our resources page, you'll be able to view the data dashboard. So this is going to be a live demonstration of some of what I shared just a little while ago. So if we look at this or we can start with the economic stability map. Economic stability is really a picture of income and poverty. So this map shows you that in Tennessee, there is a significant disparity of about $100,000 in people's median incomes. At the lower end, you have a county where the median income is $39,000. And then you have a county on the other extreme where the median income is $136,000. And that looks like on the lower end, we have counties like Grundy and Haywood. And on the higher end, we have Williamson County pretty much on its own, and then some others. So this gradient tells you just with an initial picture where the lower end is and where the higher end is. So if you want to look at a county like Davidson, for example, you'll have information about the median household income and the households that are living in poverty. So we have, just based on this, about 11% of Davidson County living in poverty, and we have an unemployment rate, and then those who are dealing with housing problems or eviction. So it's just like a way of reflecting how well people are doing at the county level. So let's just take the poverty rate. So in Davidson County, the poverty rate is 11%. And that's something that we can compare to Williamson County, which has a poverty rate of about 6%. And then we can go back to Haywood County, for example, where the poverty rate is 25%. We can also look at Shelby County, which is one of the most populous county, where the poverty rate is 17%. So numbers aren't everything, but I think when we're having a conversation about general access to care and disparities, like this is a really good start, is just to see that across these counties, the median incomes vary. Across Tennessee, the median income varies in different counties. And there are some at the lower end where almost a quarter of the population is living in poverty. And we'll have time for Q&A, so I'm throwing some numbers out. So I'm just going to move to maternal health. Maternal health is a huge priority for TJC. Maternal health, Tennessee is one of the states with the lowest maternal health outcomes and essentially the highest maternal mortality. And we have a lot of work to do in our state, and a lot of work is being done to ensure that when people are going through pregnancy, they are getting access to prenatal care, they're having safe births, and they're having resources during postpartum that they need to kind of show up as a parent, as a mother, for example, and to take care of their children, take care of themselves. So we use this map to reflect how far someone has to go to even get maternity care. This data is collected by March of Dimes, which is a very, very highly renowned national organization, and we're so grateful for their data. And then we combined it with some other information that we found on our own. So this is just a picture of how far the average person in a county has to travel to get to maternal care. I'm just going to focus really quickly on these counties right here. These are the more rural counties in Tennessee, and you'll see that people are traveling 36 to 64 miles to get any maternity care. That's from a dedicated obstetric provider, not just from an emergency unit and not from primary care. So we're talking about where are the hospitals that actually have the maternity care wards and the specialists to treat to help people who are pregnant, and we see that in these counties that is severely lacking. So in the red counties, and then orange counties, which is like that's probably a good number of Tennessee counties. There's also, it's pretty far. It's 22 to 36 miles, and then you kind of go down in distance where some counties are more like 8 to 22 miles. And then we have counties like Davidson and Wilson where people have travel on average 3 to 8 miles, which is not very far to get maternity care. So you can imagine if someone has an emergency or they have higher needs during their prenatal early pregnancy, it's just difficult in some areas for them to get to the actual provider that they need. And then, of course, maternal vulnerability. We have some information about maternal vulnerability and whether uh, children are being born with a low birth weight, which is highly connected to how healthy the pregnancy is. So you'll see the low birth weight in a county, and then you'll actually see the low birth weight broken down by race. So this pretty much corresponds um, with how much care and how quality of care somebody's receiving during their pregnancy. I'll share about health disparities. So one of the things we also care about is rural healthcare and rural hospital closures. A huge challenge in Tennessee is the closure of rural hospitals. Tennessee is one of the states with the highest rate of rural hospital closures in a state where 30% of the population, so a huge number, live in rural areas. So we wanted to reflect that in this map, which shows you the overall life expectancy for each county. So there are a couple counties with lower life expectancy. We've got Meigs County, we've got Dyer, Hickman, Grundy, Union County, and then we've got some higher outcomes like we've got again Williamson, Davidson, Wilson, Rutherford, and so on. But we wanted to reflect for those rural counties, are there hospitals that have closed in the last few years? That is reflected here very clearly. We have Gibson and Clay County, or sorry, Gibson and Carroll County. We've got Perry, Marion, Polk, and some others. And in all of these counties, you'll see that the life expectancy is on the lower end. So there's an understanding that as rural hospitals close, people are going to once again struggle to go to the doctor and to get quality care. So we wanted to just reflect that so people are again aware that where these hospitals are closing, the life expectancy is already on the lower end of the state average. And nutrition, I'm particularly excited about this map because food insecurity is a huge issue. We've gotten some great data. One thing I'll just focus before finishing up is when folks live in counties with, let's see, a county with a higher food insecurity, they're, for a comparison, so let's start with Davidson. Davidson has 115 grocery stores. This is an urban county by pretty much every metric. High population has the capital. 115 grocery stores and a 13% food insecurity rate, which is on the lower end. If we compare it to Scott County has 4 grocery stores. And that in terms of grocery stores, that's a place where someone can get fresh produce on a regular basis. If we look at some other counties with high food insecurity, Bledsoe County has no grocery stores reported according to this metric. That might not be the case. DeKalb County has 5 grocery stores. We got Benton has 4. And so when you get to areas with higher food insecurity rate, you'll see that there's just not as many grocery stores. People are getting food from dollar stores in a lot of cases, which is just the option that folks have. And so when you have lower access to the foods that people consider nutritious and healthy, it just kind of makes it harder for people to access food overall. So those are just some examples of how this dashboard is used and why it was created. And hopefully we can talk on the Q&A session about how put it together and how I kind of focused on some data points. But overall, when we talk about social drivers of health, this is what we're talking about. It's kind of the community context that people are coming from. And hopefully this is part of the conversation to improving those broader issues. So I'll stop there and turn it over to John, who I know will deepen your understanding of some of the things I just talked about. But I really appreciate you all sticking with me through that, and I'm looking forward to Q&A.
All right, well, I will just jump in. Let me see, make sure I can share my screen. All right. Okay. All right. Well, first, I just want to say thanks to Patty for inviting me to come and speak with you all today. As Patty said, we used to work together here at the Department of Health. I think so much of Patty, and she was an amazing person to work with, and just so pleased that she invited us here. Also, thanks, Patty, for inviting Jane, because Jane is amazing, and everything that the Tennessee Justice Center does is super impressive. And so I'm in really great company and appreciate the chance to be here. So as Patty mentioned, I have the opportunity to direct the Office of Primary Prevention at the Tennessee Department of Health. We're a pretty unique office. We essentially serve as an innovation office within the department. We sit in the commissioner's office. We're fairly small. We don't oversee a lot of large grants or cooperative agreements. We don't do required legislative reports or do some of the more traditional types of public health things that you might think of. We were actually created to help the department think about how it could move more upstream in its work to focus more on the social drivers of health and think about those contextual factors that impact health. So we work throughout the Department of Health. We work a lot with external partners. And this is fairly new work. And this is really foundational to the approach of public health. But in a lot of ways, we are kind of figuring this work out as we go, which is very exciting and also very daunting at times. But I want to talk a little bit about the social drivers of health, what that means to us in public health practice. And then I'll give you a few examples of some of the things that we are doing in our office. I can by no means speak to everything that happens in the Department of Health. I can't answer questions about everything we do. It's an incredibly diverse place. We have over 3,000 staff. We do everything from food inspections to providing primary care and dental services in rural areas to doing work that I'm going to talk about in our office around food security, housing, built environment. So we do a really broad range of different kinds of things in the department. So I'm only going to touch on a snapshot of those. So first, I just want to talk about what we mean when we're talking about health. So the definition that we typically use is the World Health Organization's definition. Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And this is a little bit more of a holistic definition than sometimes people think of when they think of the term health. And I like this because it really points to the fact that there are multiple facets of health that we have to be considering at all times. And in public health, we're really thinking about how do we impact people and communities? So the American Public Health Association defines public health as promoting and protecting the health of people and communities where they live, learn, work, and play. And I think this definition is really important because foundationally in public health, we're thinking about people. I mean, we're all in public health because we want to help people. We want to improve their lives. We want to give them the opportunities to be as healthy as they can be. But we're also thinking about communities. We're thinking about systems, the networks in which people live, the environments where they live, and how those networks and those environments shape their behaviors and their opportunities. So that's really important for us in public health is we are focused on people, but we're also thinking about the context in which people live. So there are lots of things that impact our health. A lot of times when I talk about public health, people immediately go to healthcare. They're thinking about, someone going to see their primary care provider or going to a hospital or a clinic. Healthcare is necessary for good health, but it's not sufficient for good health. There's a lot more that determines our health, and Jane talked a little bit about this already, than what happens in clinics and the doctor's office. This is a really nice graphic. The McGinnis pie chart is what it's typically called, that illustrates that there are a lot of different things that are impacting premature death and health across our lifespan beyond just healthcare. So healthcare roughly impacts about 10% of our health and our health outcomes, but there are other things like individual behaviors and social and environmental risk factors that we have to consider. And of course, all these things are kind of interrelated. So the social and environmental factors that impact your health, those contextual factors are also shaping your opportunities and your choices wherever you spend your time. So these are interrelated as well, but it does a nice job of illustrating that if we're improving healthcare access alone, that's not really going to get us where we need to be. So we also have to be thinking about and addressing all of those other contextual factors. Unfortunately, we don't always direct our resources in alignment with this. So we tend to spend a whole lot more money on things like medical services than we do on other things that are those social drivers of health in our environment that are impacting our health. So we know that those contextual factors are a much larger percentage than what we're investing in. And so there's kind of a mismatch in where we're putting our dollars versus where we're really going to get the most for those dollars. You can see here healthcare spending per capita in US dollars. So we are way down there at the end at the very top in red, along with many other peer countries. So we spend more per capita than anyone else on healthcare. And we don't spend quite as much on things like social care. So social care, these are services that are really considering things like social drivers of health. So things, policies and funding for things like childcare and paid time off, things that really determine the economic stability of families and people's ability to save money, to get ahead, to be able to afford the things they need, like housing and healthy food and health care. We don't tend to invest as much as some of our peers in those social care benefits in our society. And so we kind of see some unfortunate effects of that on the back end, because it means that if we're not investing up front in some of those things, that we end up spending more in the long run on healthcare to try to address some of the problems that we've caused. So as you can see, we rank 34th in life expectancy at birth among the countries that you see here. So we're not really getting a whole lot for the way that we're investing. So we really need to be thinking different about the way that we're investing and the way that we're approaching health in the US. I also want to point out some of the leading causes of death here in Nashville. This is a little bit of an older list. This is from 2019, so this is pre-pandemic. This list doesn't really change much over time, except COVID-19 is actually on here now. But you tend to see the same list roughly from city to city, state to state, and across the US. Typically, what's killing us is heart disease, cancer, stroke, diabetes, a lot of chronic conditions. These are very preventable conditions. And the things that cause things like heart disease and diabetes and stroke and cancer, they're multifaceted. It's not just one thing that causes these. It's a variety of different factors that are all interacting to produce this list. And so these are complex things to address. When we're talking about preventable chronic conditions, it really takes effort in a lot of different places all at once. And so these are not easy things to solve. So I think this is a really nice graphic to illustrate what we're trying to do in public health. So this is the health impact pyramid. This was created by Tom Frieden when he was at the CDC. And this illustrates how we think about where we invest in health, the amount of effort that we have to put in versus the impact that we get for that effort. All of these are essential. It's important to provide things like counseling and education and clinical services where we're really focusing in on individual level interventions. But in public health, we really want to make sure that we're mostly focusing on the bottom of this pyramid. So we really want to think about changing the context so we're making individuals' decisions healthy by default, making the healthy choice the easy choice is another way to put that, and thinking about things like socioeconomic factors. So if we can change the context so that we're setting people up for success, so that they have a better chance to be healthy, they have that opportunity, that choice is easier, then we're going to have to spend less effort and less money on the back end providing clinical interventions and some of the other more individual focused interventions that we see at the top of the pyramid. I mentioned the term moving upstream. This is a term that we use a lot in public health to talk about addressing contextual factors and social drivers of health. Upstream means that we're thinking about the root causes of disease and how do we address those root causes to reduce disease incidence and prevalence. So if you ever hear that term upstream, that's what it means. We're thinking about larger impact, community impact, changing systems, changing environments. And we've really institutionalized this in the Tennessee Department of Health. So in our most recent state health plan, Tennessee Department of Health has social determinants or social drivers of health front and center. So we are advocating for things like education access, economic stability, neighborhood and built environment interventions, addressing social and community context. These are the things that we need to be focusing on. And our state health plan really, it's for us, but it's also for our partners. Because if you notice some of the things here in this graphic, things like education and built environment and economic stability, those aren't always things that we directly impact within our sphere of control in public health. And that means it requires us to build partnerships and relationships with others that are making policy and decisions in these spaces so that we can bring health to the table. We can bring that health perspective, health data to make sure that as others are making decisions, that they are also considering health and the impacts on health. So this is really a document that's intended to inform others as well as ourselves and to kind of bring us together. Jane talked about equity a little bit already, so I won't go too deep into it. I like to think of equity as giving people what they need. Different people have different needs. They're starting from different places. Equity is about directing resources and the right resources where they're needed the most. And so this is a lens and a framing that we use in the work we do in public health. It's also helpful, I think, to note that when we talk about inequities, we're talking about things that are systemic and affect entire groups of people. And those produce health disparities. So a health disparity is a difference in health outcomes between groups of people. And health inequities are those systemic factors, those contextual social drivers of health that are creating those health disparities. And addressing health disparities is really foundational to public health. We know that some people get more sick than others, and we need to know why, and then we need to know how to address it for those specific populations. So we're always working on addressing health disparities. It's foundational to what we do. I know the language health equity has really come under fire recently. People have to be careful when they use that language sometimes. That's the reality of it. But addressing health disparities and understanding those contextual factors and addressing them is foundational to what we do, and we're always going to do that. So in our office, in the Office of Primary Prevention, we have a few core areas of work. They fall into these buckets: community engagement, built environment and health, workforce and professional development, cross-sector collaboration, and food and nutrition security. So I'm going to touch on a few examples of each one of these. Some of the key initiatives that we manage in our office, one is when we're thinking about our environments and how they shape our health, we often talk about the built environment. The built environment is the spaces and places around us that have been shaped by human hands. It's everything. It's buildings, it's streets, it's parks. It's everything that we've constructed and shaped. And all of those things impact our health in some way, whether it's positive or negative or some mix of the two. And so we have invested in our department in trying to improve spaces and communities so that people have access to healthier spaces and healthier communities. We do that in two key ways. One is through our local staff who work across the state called Healthy Development Coordinators. Their whole job is to be the liaison between public health and urban planning, housing, transportation, parks and green space, outdoor recreation, and economic development. So they are bringing health expertise, health data, research, funding, and support for initiatives that create healthy places in communities. And they primarily work in our rural areas because that's primarily where we direct our efforts at the Department of Health, because the larger cities in Tennessee operate their own health departments. So we tend to work more in the rural areas. We also have a state-funded grant program called the Healthy Built Environments Grant Program. This is a grant program that funds planning or construction of publicly accessible health promoting projects. So we have funded 270 projects in every one of the 95 counties in Tennessee. We've invested $8.1 million to date since 2017. We've funded parks, greenways, trails, playgrounds, sports facilities, farmers markets, community gardens, school gardens, crosswalks, cross signals, bike lanes, bike infrastructure, basically anything that a community applies for that is free to the public at no cost, that is health promoting and addresses a health disparity, that's eligible. We get about 10 million in requested funding per year for this. We only have 860,000 to spend, so there's a huge demand for this. So we're constantly seeking new opportunities for funding for our grant program, but it's been wildly successful, and these are projects that everyone can get behind. Everyone gets excited when we build a new playground or we build a new walking track or a park in a community. And everybody intuitively gets how that impacts health and improves health. We also manage some cross-sector groups. Cross-sector means we are working with other areas of work or disciplines to address health together. An example of that would be we're launching a group called the Interagency Housing and Health Task Force, where all the agencies that do work around housing can work together and create shared goals so that we're all aligned and we're aligning our priorities and our funding around addressing safe, stable, and affordable housing. We also have a statewide food and nutrition security coalition that's managed out of our office by Paige Summers. That's working to coordinate all the actors in the food and nutrition security space at the state level to better align the work that we're doing. We also do some work around housing. We've funded eviction prevention services to Legal Aid Society. We have funded critical home repairs and modifications for low-income and senior homeowners in Memphis. And we're also working with a couple of housing advisors right now to build work in faith and housing. So partnering churches and affordable housing developers to develop affordable housing on church properties. So kind of a creative idea that is starting to emerge nationwide. And so we're promoting that in some of the rural communities in Tennessee. And then workforce development, because we're a small office, a big part of what we do is to try to think about how we can move all of the priorities and the programs and the funding in our department more upstream and focused on those social drivers. So we do a lot of training, workforce development, staff engagement around social drivers of health and built environment and health equity so that we're preparing our workforce to better be able to do that kind of work. A really cool example of us kind of being on the ground. So I mentioned our healthy development coordinators. You can see one of them here in the blue shirt. That's Corey out in West Tennessee. We do community engagement through active living workshops, promoting walking and biking in small rural communities. So they bring together a group of stakeholders, talk about the relationship between health outcomes and active transportation like walking, biking, and transit. And then they actually go out and they do walk audits and bike audits in that community, come back and do a visioning session, create a set of goals, and then our staff help them to identify funding sources and policy changes that can help to implement those changes in communities. So community engagement, educating them about the health benefits, and then also being able to follow up and find resources to be able to make communities more walking and biking friendly, especially in a lot of smaller kind of rural downtown areas. I mentioned our Healthy Built Environments grant program. We have lots of great pictures. That's one of the beautiful things about doing work in a built environment, is that you have something that you can take a picture of at the end. So we have lots of great pictures. Here are a few of those. A pump track up in the Tri-Cities up here in the top left. We've got a greenway, a trailhead master plan for Cumberland Gap, an inclusive playground in Carroll County up there in the top center, and then outdoor exercise equipment at a park, and then another walking track at a school down in the bottom. So whole variety of different kinds of things that we funded. I mentioned cross-sector groups, so we have quite a few of them. I mentioned the Food and Nutrition Security Coalition. We have 230 participants in that right now and continuing to grow. It's been in existence for about a year. We have our annual in-person meeting coming up in partnership with UT as part of One Health Day in Knoxville next month. That's a really incredible coalition. We're working with some academic partners as well to be able to kind of guide that group and its priorities. So definitely using data and definitely using kind of on-the-ground experience to help inform the work that that group is going to do. I mentioned the Interagency Housing and Health Task Force. I also support the Tennessee Outdoor Partnership in my role, which is managed by Tennessee's Office of Outdoor Recreation. So bringing health into that conversation and into the outdoor recreation and rural economic development work that we do. And then at the top, actually, you see the Tennessee Livability Collaborative. That is a statewide health and health policies group. We have 26 state agencies, departments, and commissions that meet every other month and talk about ways to align and collaborate. And that group has been kind of an international model for cross-sector collaboration in public health. I think I've mentioned a lot of these housing initiatives already. I did not mention our healthcare and housing summit. So we're also thinking about ways that we can make the case for healthcare to invest more in housing. You see this happening a lot for, especially for high-cost patients who tend to get a lot of care in the ER. Thinking about ways that you can provide housing supports to help improve health and reduce healthcare costs. So we've been convening partners in that space, and then also working on some creative new housing ideas like a perinatal housing demonstration project. Housing is one of the primary risk factors for health outcomes for pregnant moms and their babies. So looking to fund a demonstration project to be able to provide housing supports for women during the perinatal period, excuse me. So what we've learned as a kind of Office of Innovation, I guess, over the years is that we engage in a lot of different spaces and we do it in a lot of different ways. So we've first of all learned that we need to listen first. Whenever you're doing this kind of work, you need to listen to the community and know what their needs are. You need to listen to your partners. If we're working in the housing space, we need to engage with housing experts and we need to understand why the housing systems are the way they are and how maybe we can bring some resources to support making them better. So listening first is a really good lesson we've learned. We do a lot of facilitating in public health. We see things holistically. So a lot of times we're the conveners. We're bringing people together to collaborate and work together. You hear a lot about, government working in silos. I don't think that's so much the case anymore. You really do see a lot of collaboration and people who are very willing to collaborate. And so even though that does still happen sometimes, there's been a big shift even just in the 8 years that I've been at the state. And so often we are ones who are bringing those groups together and facilitating them. Sometimes we're just participating. Sometimes we're part of someone else's group and we're the health voice at that table and we're bringing health data and research and expertise and sometimes health funding. Sometimes we have funding that's flexible enough that we can bring it in a new creative way. And that's part of what we try to figure out in our office as well. Sometimes we're challenging others. Sometimes we know a policy is not good for health or a program is not doing what it needs to do. So sometimes we're coming in and we're building relationships, but we're also challenging the status quo. We're often educating. We educate our partners. We educate our staff. We provide education to communities so that they better understand the health implications of of policies and environments. We bring staff. We have people on the ground working in communities across the state, and we have staff working with our staff in the Department of Health. So we're bringing people, and then we're bringing funding. So we have our Built Environment Grant Program, but we also leverage funding from a number of federal funding sources, often in creative ways. Some of those interesting housing initiatives I talked about with eviction prevention and home repairs and modifications, we used a COVID disparities grant for that. That was a pretty unusual, creative way of using some federal funding. We can justify it because we know that those are sort of upstream interventions that can prevent people from getting COVID or having as severe a case of COVID. But it takes some creative thinking to think about how you can use some of those flexible funding streams in new ways. So we're always thinking about new sources of funding and creative ways to use our existing funding. So that's what I've got. Happy to answer any questions that I can, and my email's right here. So if you ever want to email me and chat or have other questions, feel free to reach out anytime. Thanks.
Looks like there were a couple of questions in the chat, and maybe what I'll do, I don't know if you all can see those, Jane and John. There's one for Jane and one for John. Why don't we start with Jane, and then John, you answer the next one, and then, you know, everybody else can just we can be open for other questions.
Yeah, so I got a great question about the economic stability map. So one of the things that I had shown is median income, but there was actually another feature, another measure on that page called ALICE. So if you haven't come across it, ALICE is a measure through the United for Alice organization. It stands for Asset Limited, Income Constrained, Employed Households. So these are the folks who are not under the poverty level, but they make with the amount of money they make, they still struggle to make ends meet. So they're above poverty, so they categorically will not qualify for things like Medicaid and SNAP and the kind of programs the TJC works on, but they might still struggle to pay for healthcare costs, pay for housing costs, pay for education costs, and things of that nature. So Alice really calculates folks who are caught in between poverty and being like high income to the extent that they don't struggle to make ends meet. So on the map, if you're looking at a given county, you can actually see, we can stay in Davidson, you can see the total number of households and the households that are in poverty. So it's 11%, which we were talking about. And then the households that are in that Alice, caught in that Alice in between, about 30%. So 100 and almost 103,000 households are making enough that they're not high income, they're making enough that they're not considered in poverty by the federal guidelines, but they're still struggling to make ends meet. So I think that's a helpful measure, and alongside looking at how many people are in poverty. And then of course you can see what percentage is just completely above that Alice number. So they are not considered struggling to make ends meet by this definition. So it's just a helpful measure to look at alongside poverty, like who's struggling in that in between. So thanks for picking up on that.
Right. It looks like the next question was from Catherine. Hey, Catherine. So yeah, that's a really good question. It is very difficult inherently to measure prevention efforts. It's hard to measure what you kept from happening, basically, is the shortest way I can put it. So I will tell you kind of a very practical approach that we take to evaluation. But I mean, I think the short answer is it's really, really tough, and people struggle with this in public health because we know that this is the approach that is most effective and efficient for improving health, but it's very hard to show that. So what we oftentimes do is we look to the research and we say, okay, the research says that these interventions are going to make a difference. And so we try to focus on that and then sort of cite the research. For the built environment work, we actually do require every one of our grantees to conduct an evaluation of their project. We approach this in a very practical way because we have them for 2 years. So they have a 2-year maximum to do their project. And so we know in a relatively short time, they have 6 months to complete their evaluation after. We're not going to see changes in population health in terms of diabetes prevalence or heart changes and deaths from heart disease because we built a new park or a playground. We know that we're sort of investing for the future. We know that these are things that do impact physical activity or healthy eating or other things that we know are going to impact people's health. So we're creating those opportunities, but it's really often hard to measure. What we tend to focus on for our grantees, we let them design their own evaluation. So they create an evaluation just for their project. We ask them to build a logic model. We don't even call it a logic model because people get terrified when they hear that term. So we call it a process flow chart. And so they create a logic model and we ask them, like, what are your goals for this project? What are you trying to achieve ultimately in terms of health? And then they kind of work backward from that and they kind of map it out. Okay, this is what we're going to put into the project. This is what we're going to build or do. This is what we think is going to happen. It's going to change these behaviors or change access to a green space or a physical activity space. And then we know from the literature, from the research, that if we create that opportunity, that people are more likely to use it, and that's going to improve health over time. So we try to just help them map out that logic, that theory of change. And we have a position in our office that helps support that and to help them kind of build that out and think about it and design their evaluation and conduct it. So we try to think of it very practically, like what can you measure in the short term? Oftentimes we're asking people to look at changes in behavior of people. Now that we've built this park, do people have greater access? Are they more physically active? Are their kids more physically active? So thinking about some of those short-term goals that they can measure that we know could lead to long-term change. So a lot of times we know we're investing in the future. It's hard to make the case, but the good news is for some of this work, I think it is pretty intuitive. People understand if you have a safer, healthier home or you have a new space for physical activity in your community, that's probably going to be good for your health. So it's a challenge, but we do the best we can with what we can do in the short term.
Oh, can I ask a question? Oh.
No, it's just, are there other questions? Jane, you were.
Yeah, I think one thing that I really love about the dashboard is that it's very location specific. And so it allows people to connect with information wherever they're from. So if you're from Davidson, I figured this particular group is based here in Nashville. So I focused on Davidson. But I'm just curious if folks have other counties that they're interested in learning more about, or when you look at the dashboard, what appeals to you? Is it maternal health? Is it behavioral health? Is it nutrition? I guess I'm just curious how folks are coming into this conversation around community access, community health, and what we can do to make sure people are healthy in more ways than one.
Something that stood out on the dashboard to me, and thank you so much for the presentation, was the comparison you made between grocery stores, how many were available in the population size, because there are quite a few grocery stores in Nashville, but there's still areas that are considered food deserts. And you talked about like Dollar General as a last resort and how that kind of increases inaccessibility to food. I thought that stood out a lot.
Your email.
Claire, do you not have your mic on? Can't hear you. Give Claire a second. Well, maybe while we're waiting, I do know that we have quite a few folks from our public health group that are physicians and nurses, healthcare professionals. And maybe if John, you could talk a little bit about the link with the clinical community, sort of the clinical connection in the Office of Primary Prevention and what kind of work you all have done with, I mean, I think especially like the local health departments that provide a fantastic service out in their communities. Can you talk a little bit about that?
Yeah, sure. So, I think a lot of our providers and probably providers anywhere have stories about patients where once they really get to know the patient, they start to understand all of those contextual things that are really difficult for them to change, and it's hard for them to change their behaviors. And so I think a lot of clinicians, nurses, and doctors kind of start to learn, hey, there are these other factors that I can't really control in my role as a clinician directly with my patients. What can I do about that? And I think, there's certainly a few things that you can do. I think there's some creative, interesting things that people are trying, like park prescriptions and produce prescriptions, where you can actually provide prescriptions for some of those things like physical activity and healthy foods, to try to encourage people to do it and just to think about that as a solution to some of the health challenges they might be facing. We've also created a training series in our office that focuses on social drivers of health, that's open to anyone. And we've had a number of clinicians participate in it. And it's really focused on educating about social drivers of health. And then what are some of the policy levers and the decision-making bodies in communities that help to shape those social drivers. So talking about things like school boards, planning and zoning commissions, who are the entities that are making policy decisions, and how can you as a public health practitioner or a clinician engage with them? And Patty's done a lot of work in this space with nurses on boards. And, I think it's really important for clinicians to be out there talking about the health impacts of things and directly engaging in the decision making, educating policymakers, but also serving on those boards, and being an official, voting member of those boards. So you can engage in your community outside the clinic walls, and I think that that's another approach that we advocate for. And I think the final thing I would say is, we also have a strong focus right now in the department on addressing social needs in our clinics. We can do screenings for patients for things like food insecurity and housing issues. And when we screen for those, we have a referral system now called Find Help that we're about to launch, and TennCare is using the same one. So we're working with TennCare on this, but we'll launch that on our clinics, and that will ultimately be a closed loop referral system. So we can refer patients to services, and then we can see if they access those services. And that's essentially a library of all different kinds of things that we can refer them to based on that screening that can happen in the clinic. So not necessarily changing things systemically, but definitely addressing some of those proximal needs that are sort of non-clinical factors.
Thank you. It's nice. It's nice if you write a prescription for physical activity, or we have used park prescriptions, the Park RX program, that once a park is built or playground is built, you can actually say, here's your prescription, talk about physical activity and the importance, and then it makes it real. It makes it real. Not just a go exercise. Thank you, John. Are there any other questions? Because I think we're about at the end. We're right on time.
I have a brief announcement that I need to make once we've wrapped up.
I think you go ahead, because I think I'm just going to say thank you to John and Jane. Amazing. You all are just wonderful. I love the work you're doing, and we really appreciate it. It gives us a lot of food for thought in our work in the league. Yeah. Okay.
Yes. Thanks very much. I wanted to just draw attention to next month's hot topic, which will be on October 3rd. And pay attention, this hot topic is going to be in person. We are not going to be on Zoom. We are going to hear, our speaker will be Frida Player Peters, who is the current chair of the Metro School Board, also a former member of our Lake Board. We will be meeting in the school board chambers, which is at 2601 Bransford Avenue. So we look forward to seeing any of you who are interested in current state of metro schools. Thanks very much.
Well, thank you all for attending. I look forward to that. Sounds awesome. That sounds really great. Love to go to the school board. Makes me feel like maybe we could get something done.
Thank you. Thanks, Patty, for
Thanks.
organizing this.
Thanks. Bye.